Hello, welcome to my presentation that I've entitled Trauma 101, focused particularly on understanding childhood trauma. My name is RMiller, and I'm a assistant professor here, a clinical psychologist at the Department of Psychiatry and Behavioral Sciences at UNM. And I am basically an outpatient therapist, and I also do testing with kids, but I focus particularly on families who have experienced trauma. So I'm particularly excited about this topic. I will say this is my first time doing a recorded presentation, so I'm a little nervous. I will try and not speak too fast, but let's get started. So I just first wanted to go over what my goals are for today for all of us. First, we're going to go over just generally what is trauma and focusing on what are different types of trauma, and then moving more into how does trauma affect us as individuals. We'll first focus on PTSD and what are the different signs and symptoms of PTSD. But then we'll take a more global look at how does trauma impact overall a child's functioning or a teenager's functioning, and even looking at families as well. I will say that although this is a recording, I do hope that when you're watching this, you are engaged in the presentation. And what I'm going to do is at different points in the presentation, I'm going to ask some questions, and I'm going to ask you to really think about the answers. You can either jot down your answers or just reflect on it, but I will pause at different points to allow some time for that. So just a heads up so it doesn't seem awkward. Okay, so first talking about trauma. What is trauma? So this is a nice definition that I found on SAMHSA, that SAMHSA has come up with. And it says, trauma results from an event, a series of events, or a set of circumstances that is experienced as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, and or spiritual well-being. So it's a pretty big definition. It's really all-encompassing, highlighting how there's an event or a series of events that really impacts an individual's overall well-being, or can impact, I should say, an individual's overall well-being in each and every capacity. So I want you to take a moment and think about this definition and think about if that's how you would define trauma, or if you have a different way of conceptualizing or thinking about trauma. And I also want you to think about what would fall into that category? What are the different types of trauma? What do you consider to be traumatic? So what I'm going to go through here is a list of different trauma types. It is an extensive list, but not exhaustive. And for some, I will go through, there's some terminology that people may use differently. So I'm going to go through, for some of them, what we consider to be examples of these types of traumas. And I've divided in half into two lists, but it's just to make the screen less busy. So some trauma types, I first really listed different types of abuse. So we have sexual abuse, inappropriate touching or exposure to sexual content or materials or sexual activity, physical abuse, emotional abuse or psychological abuse, domestic violence. Now with domestic violence, thinking about from a child's perspective, there's a lot of different ways a child may experience domestic violence. There may be what often comes to mind for people is witnessing domestic violence, which of course is unfortunately a common experience for our families, but as well it could be overhearing domestic violence. So without witnessing it, perhaps a child is in another room and hears it. Or sometimes, sometimes people think, well, the child wasn't home when it happened, so it doesn't affect them. But we'll see kids sometimes who learned about the domestic violence perhaps by seeing a parent with injuries, or seeing a parent being arrested. And that, would really fall into the category of witnessing domestic violence or the sequelae of domestic violence. A lot of our kids, unfortunately, have experienced neglect or abandonment, a failure to have their basic needs met, whether it be malnutrition, not having a stable place to live or sleep, not being sent to school or not having medical care. We see kids who've had, of course, medical trauma or are in accidents. I put bullying on this list, which sometimes when I do this presentation as a surprise to people, and thinking of, oh, well, we're all bullied once in a while. But really, bullying is pretty pervasive, and we see some kids who've experienced it to such a degree, to such a chronic degree, that it can become traumatic to them. Not knowing who to trust, or not being able to interact, have appropriate relationships with peers. Of course, being physically harmed would be traumatic as well. But we unfortunately see a lot of cases of that, and that can have chronic impact on this child's ability to form relationships. Another common one that we see is living in chronically chaotic environments. So if you think of a family who, let's say, has multiple people coming in and out of the home, there's always a change in who's caregiving for the child. Perhaps they're moving a lot. Perhaps there's lots of events, sudden events that happen in the home, whether it be a police raid, whether it be people getting arrested, whether it be substance use. But it's not just looking at those each individual events, but really just the chaos that happens throughout this child's early development that can in and of itself be traumatic. Death or separation from a loved one. So it's not uncommon for people to think of death, particularly a traumatic or sudden death, to be traumatic for a child, but also separation. So if we think of a child who, let's say, is put into foster care, and now they're separate from not only their parents, but perhaps their siblings. A parent who's incarcerated, or sibling who runs away and is missing. All of those could for sure be traumatic for kids. Having a caregiver who has significant medical or mental health issues. Sometimes that, particularly the mental health side, can fit in with the chaotic environment. If you have a caregiver who's struggling with their mental health and is very chaotic in and of themselves, or unpredictable, that can be really scary or traumatic for a child. Similarly, caregiver substance abuse can be traumatic. Home displacement, so having to be relocated, particularly in a sudden way. Let's say there's a fire and a family has to leave, or there's other factors that cause a family to all of a sudden get up and move. That could, depending on the circumstances, could be traumatic for a family. Community violence, of course, shootings, seeing fights, seeing just overall violence and unpredictability in the community. Historical trauma, which I won't spend a ton of time on because I'm honestly not an expert in that area, and it's its own big topic, but really in considering not just what this child has experienced, but what has their family throughout the generations experienced that's been traumatic, and how does that trickle down throughout the family and impact the family's culture and how they function in this world. War trauma is one that often comes to mind when we think of trauma, and was really one of the first ones that was thought about when the diagnosis of PTSD came up, and even when PTSD treatments were initially developed. We have life-threatening natural disasters and witnessing police activity, which is another common one that we see with our families and is not always thought of as traumatic. But, if a child is, let's say, experiences a police raid, or seeing people get arrested, or just the police coming to the home and the flutter of activity that happens around that could be traumatic for a child. So in addition to thinking of not just the different types or incidents of trauma, we also think of trauma as happening in really two different types of categories. And the reason why we think of it this way is because there's really different implications for how that affects a person, depending on which category of trauma their experiences fall into. So I wanted to spend some time talking about what the difference is here, and we're actually going to come back to this a little bit later when we talk about the effects. So first, focusing on single incident trauma. This would really be a single discrete event that an individual experiences. So if you think of car accident, a sexual assault, a school shooting, while it can be incredibly traumatic, it's a single event that is happening. Now, that's not to say that there aren't sequelae from that event that can also be traumatic. So if we take the example of, let's say, someone who's in a car accident, sure, they have the car accident, but it's not that, okay, the accident's over and they are fine per se. Perhaps they need to be in the hospital. They may need to have a surgery. They may need to talk to the police depending on the circumstances of the accident. There may be life changes that have happened because of the results of the accident. So this isn't to say that it's a simpler experience, but it's really focusing on one specific event that happened and events related to that. The reason why we really differentiate this from the second category is because individuals who present to treatment with as having experienced single incident trauma typically respond relatively well to treatment. So the trauma treatments that are out there, which we won't spend time on today, it's really beyond the scope of this presentation, but the trauma treatments that are out there really, especially the ones that have been out there for a while, were really designed to treat the single incident trauma, particularly, or trauma happening in adulthood, really. So in part, that's a reason why these individuals respond better to treatment, but as well as oftentimes these individuals, in theory, the rest of their life we wouldn't consider to be traumatic, right? So there's this sense of normalcy that we're trying to get back to with this individual. So that really helps to have a sense of, okay, we are in a state of distress now, given the events that happened, how can we help you get back to, you know, the way things were before, so to speak. And also, these individuals present with symptoms that, if they meet criteria for, they more often fit the diagnosis of PTSD. The diagnosis of PTSD, which in a few slides we will spend some time going through those different criteria, we'll see that it's designed for really single incident trauma and focusing on the single incident trauma. So understandably, these individuals, when they have PTS symptoms, tend to fit this diagnosis better. Then we have our second category, which honestly we have a lot of kids and families present with. I'd say, unfortunately, more often at our clinic, we see families who have experienced chronic trauma as opposed to single incident trauma. And another term that you may be familiar with that chronic trauma is interchangeable with when considering kids is complex developmental trauma. So this would be an individual, a child who has experienced multiple types of trauma. It's been chronic and a prolonged exposure. Oftentimes these traumas are severe, they're pervasive, and they're interpersonal in nature, meaning that it involved interactions with other individuals and that were traumatic. So for example, if you think of a child who, let's say, was born drug exposed and their parent was still using substances, and so they, you know, sort of inconsistently could meet the child's needs. The child experienced or witnessed or was exposed to in some way domestic violence as they were being raised, and perhaps the child also experienced abuse themselves, right? These would be multiple chronic traumas that are impacting how this child is developing. These usually begin early in life, and because they're occurring at the key points of stages of development, you know, when a child is learning not just how to walk and talk and toilet train, but just as importantly, they're learning how to regulate themselves, how to interact with the world around them. They're learning about how to interact with people and relationships. When those experiences are fraught with trauma, their development is going to be impacted by that. So, for example, their ability to form a secure attachment may be severely impaired if they have experienced all these, let's say, abusive experiences in their relationships. Oftentimes, children who've experienced complex developmental trauma their symptoms do not fit the criteria for PTSD, and sometimes even other diagnostic categories. So what is most common with these cases is you may get them and you'll see that there's a list of 4 different diagnoses. Maybe they're diagnosed with ADHD, ODD, depressive disorder, and, you know, I don't know, maybe autism. You actually see that a lot. And all these diagnoses that, you know, it seems like, yeah, sure, maybe there's some of this stuff going on, but you know, you're seeing this 6-year-old and wondering, how is this little 6-year-old having all these diagnoses? Well, what we find is happening is we unfortunately don't have a diagnosis as of yet that really fits for complex developmental trauma. And there is a group of people out there who is working on developing that. They're actually right now working on a measure to kind of measure and assess complex developmental trauma disorder, if we could create that. But what's made it so difficult is individuals who've experienced complex developmental trauma present with such a wide variety of difficulties that it doesn't quite fit into one category. And since we diagnose based on these categories, it's been really hard to have anything fit. We will talk a little bit about what has been done in the meantime that I think is a good move. But the goal is hopefully over the next, maybe the next iteration of the DSM, that there will eventually be a complex developmental trauma disorder. The issue with not having this disorder, and particularly with the last version of the DSM where it was either PTSD or nothing, is there's not a way to communicate to other providers that this child has experienced trauma in terms of diagnoses. So you may see a case and it looks like, oh, there's ADHD and ODD, okay. But it's really not saying why are these behaviors coming up? So this is something that is out there and being worked on, but these kids often present with many diagnoses. Okay, so I'm going to spend a little bit of time talking about stats, not too long just because they can get boring, but just to really highlight the prevalence, unfortunately, the prevalence of trauma. So in this first study, they found that by the age of 16, more than 2/3 of youth had experienced at least one traumatic event. It's 2/3 by the age of 16. And more than 33% had reported exposure to multiple kinds of trauma. More than 20% of these youth had experienced school emotional and physical problems. So that's to say it's not just that these kids have experienced stressors, significant stressors, but it's impacting how they're functioning in their life. And among the youth that had experienced more than one trauma, the rate of these difficulties was almost 50%. Again, that's speaking to the slide before, that complex trauma, the chronic, repeated exposure to trauma has a very significant effect, a much different effect than a single incident trauma. And now that's not to say that a single incident trauma is no big deal. I mean, that in and of itself can have very significant life-altering effects. But then when we look and we have someone who has had multiple of those events, the effects are even more. The national average of child abuse and neglect victims in the year 2013 was about 9.1 victims per 1,000 children. And this last stat on the slide actually always kind of, gets to me. So young children exposed to 5 or more significant adverse experiences in their first 3 years, so between the ages of 0 to 3, face a 76% likelihood of having 1 or more delays in their language, emotional, or brain development. So that example I gave before of the child who's, let's say, born drug exposed, their parent can inconsistently attend to them due to their substance use, they're not getting their basic needs met consistently, they're exposed to domestic violence, and let's say they experience abuse, let's say at age 3, they're at a 76% likelihood of having delays. That's incredibly significant. And when there's these delays, these are things that are long lasting. So it's not just like, okay, well, they go to therapy and whoop, it's better. These are significant long-term delays that this child is going to have to, or the provider is going to have to learn how to help this child with. And even with services, there likely are long-term effects. A few more stats regarding sexual abuse. By age 18, as many as 1 in 4 girls and 1 in 5 to 6 boys will experience some form of sexual abuse. In this study by Finkelhor, that looked at 1 year in time, 1 in 5 children had witnessed violence in their family or their neighborhood. More than 13% of the children in this study reported being physically bullied, and more than 1 in 3 said they had been emotionally bullied. In 2007, there was approximately 149,000 cases of child physical abuse reported in the U.S. That includes the District of Columbia and Puerto Rico. And looking more close to home, in the year of 2006, 21% of children in New Mexico had experienced physical abuse. And our last stat on this page is, again, close to home, New Mexico, 55% of domestic violence incidents involve children being present at the scene. And so one thing I want to highlight about these statistics is this focuses on what we know, right? On what's been reported, what's been known. And the reality is there's an incredible amount of trauma, particularly trauma within the home, within the community, that does not get reported and is not known. So we have these stats, and what I always think of when I see stats like this is, wow, it's actually that much more. right? This is only what we know. And so given that, I wanted to spend a slide talking about trauma and disclosure and the reality that many individuals, whether children, adults, don't disclose their history of trauma. In fact, there's a statistic out there, and this is specific to sexual abuse, but I often will share this statistic with families who are coming in and their child has experienced sexual abuse, and it's that 10% of individuals who experience sexual abuse disclose across their lifetime, meaning that only 10%, right? So there's 90% of individuals who don't disclose. And so I want you to take a moment and think about, not just specific to sexual abuse, but about trauma in general, the reasons why a child may not disclose. So some reasons that we know, and again, this is not exhaustive, so I'm curious if you've come up with some other reasons that are not on this list. But number one, not knowing that is something to disclose. So if a child has grown up experiencing, let's say, violence in their home, they may not know anything different, right? So they may not know, oh, this is something I should tell my teacher about, or this is something, this is just my life. And people, aren't always just upfront about, oh, here's what my day-to-day looks like at home, particularly kids. So they just don't know that this is something to tell. Also, not having the language to disclose. So let's say a child knows this doesn't seem right, I should tell. They may not know how to tell, right? How do I describe what's happening in my home or what's happening in my community? Some children struggle to identify a safe adult that they can disclose to. They may feel that or it may be true that all the adults that they are around are not safe people to talk to. Whether it be, it's all that everyone in their home that's in some way related to the trauma, whether they don't feel comfortable in school to disclose, but they just may know or want to tell, but not know who to tell. Sometimes there's been directly threats made to the child. They perhaps have been told, don't tell, this stays within the family, or this stays between you and me. And if you tell, X, Y, and Z will happen. So sometimes if the child has been threatened not to tell, either threats to themselves, to their family, or to others. If a child is aware of the system, or perhaps has been told about how it works, they may be fearful that they're going to be removed from their home. They may have been told CYFD is going to come, or mommy's going to get taken away if you tell anyone. So that's a real fear. Although this person may be hurting them or causing, not taking care of them in an appropriate way, the child is likely still attached to them in some way. There is some relationship there, whether healthy or not. And so they still have that connection and may not want to break that. They also may be fearful that no one's going to believe them. What happened or what they experienced may be so, they likely don't have a conceptualization of that, of, oh, this is what abuse is. It's just what they've lived. And so they may be fearful, no one's going to believe what happened to me. This doesn't happen to anyone else. They may also have been told, no one's going to believe you. Some children fear that they're going to get in trouble if they tell. So, that being a big reason they don't tell. Perhaps they've been told they were going to get in trouble, or that's just a belief system they have. And similar to, as I mentioned before, they may be fearful of the adults involved getting in trouble, right? So I don't want daddy to go to jail, or I don't want, the police to come, whatever it may be. So I'm not going to say anything. And then as a more internal experience, there may be shame or guilt. So a child may feel shameful or embarrassed or in some way responsible for what happened, and are worried about how others are going to think of them if they find out. And so it's just better that I don't tell. So there's lots, looking at this, there's an incredible amount of reasons why children don't tell. So we're going to spend a little time considering diagnoses. As I said, we'll spend some time considering diagnoses, and then a little later we'll talk about the more general global picture of how trauma impacts functioning. But I first wanted to give a list of some diagnoses that can be trauma related, meaning that it is not uncommon to, when we have an individual present to us and they've experienced trauma, these are different disorders that may be on their list of diagnoses. Now, there are some disorders on here that many people experience and have not experienced trauma. So this is not to say these are trauma-only diagnoses, aside from the first 5, really. But as I mentioned before, many times people present with other diagnoses that are not the trauma diagnoses. So I wanted to list some of those. So quickly going through them, as I said, the first 4 or 5 are definitely trauma related. You'll see that if you were to look at their criteria in the DSM. Acute stress disorder and PTSD are related. Basically, acute stress disorder being a diagnosis that you can give, I think it's 3 days up to 30 days after a trauma occurs. So it's really focusing on that acute period of time immediately after the trauma. The reason why you cannot diagnose PTSD until a month out is because it is reasonable that someone's going to have symptoms of post-traumatic stress immediately after a trauma. Right? If I experience a car accident, it's reasonable that I would be perhaps avoidant to get in a car for a bit, and I would be hypervigilant about what that's like. I'm experiencing physical distress around it. We would not say, oh, this person has a disorder, right? So the criteria for acute stress disorder are actually a bit different than PTSD, and it's really looking at what goes above and beyond what we would expect someone to experience in the immediate aftermath of a trauma. Then looking at a month out and beyond, we might diagnose PTSD. And in the next few slides, we'll go through those criteria. So a new diagnosis to DSM-5 is this other specified trauma and stressor-related disorder diagnosis, which I personally am a big fan of and use a lot. So with DSM-4, we had acute stress, we had post-traumatic stress, we had adjustment disorder. We did not have any disorder that captured this global category of a person having PTS symptoms, not quite meeting criteria, but is really functionally impaired. Thinking of those complex developmental trauma cases. And so with the DSM-5, they've now created this disorder that's pretty general. It doesn't have criteria. It's really about someone presents with symptoms of post-traumatic stress that don't meet criteria for PTSD, but are causing functional impairment. In those cases, then you could give this diagnosis. So I actually probably give this diagnosis more than I do PTSD because I work with a lot of kids with complex developmental trauma. And this at least fits a little bit, right? It doesn't really tell you what those symptoms are, but it tells you that this individual is experiencing difficulties as a result, at least in part as a result, of experiencing traumas or significant stressors. The next one down, the complicated or traumatic grief, actually, this other specified trauma diagnosis can be given in those cases. We also have reactive attachment disorder and now disinhibited social engagement disorder, which used to just be reactive attachment disorder and has since been split out into 2 categories. But this is another trauma-specific disorder that we only diagnose when we know a child has experienced disrupted attachment neglect in those early years, and therefore that's impacting their ability to have appropriate attachments moving forward. So then we have dissociation, which actually can be, when it happens enough, it can be its own diagnostic category. But it's also a specifier for PTSD, meaning that it could be a symptom of PTSD. So it's not uncommon for individuals with PTSD to have dissociative experiences. We then have, depressive disorders, anxiety disorders, and I have on here disruptive mood dysregulation disorder, which was another new diagnosis to DSM-5 and was created in part to replace all these kids that were being diagnosed with bipolar disorder inappropriately, but that we didn't have this mood dysregulation disorder to capture. So now we have this DMDD category. But I actually find that some of the kids I treat who have complex developmental trauma fit into this disruptive mood dysregulation disorder. And if we think about it, I'd said earlier on, kids with complex developmental trauma often present with just dysregulation across the board. This speaks to at least the mood piece. Individuals who've experienced trauma can also present with anxiety disorders, somatization and conversion disorder, which is really the physical manifestation of emotional distress. And then considering more teens and adults, substance use disorders, alcohol use disorders, and personality disorders. So thinking more specifically of PTSD, although I said there's many who don't fit this category, I wanted to spend some time at least going through the symptoms because there's many individuals who have the symptoms. But first focusing on how DSM identifies what a traumatic experience is. I will say it's better than it was in DSM-4. I personally still think of trauma in a more global way than they list here, but we will look at what they say. So traumatic experience is exposure to an actual or threatened death, a serious injury, or sexual violence in at least one of the following ways. So this could be directly experiencing the traumatic event. It could be witnessing in person the events as it occurs. So let's say witnessing domestic violence. It could be learning that the traumatic event occurred to a close family member or friend. And in cases where there's actual or threatened death, the event must have been violent or accidental. So this, and the reason that's in there is, let's say you learn that a family member has cancer and is going to die eventually. The idea is that there's time for grieving and there's time to prepare, and that may be different than if someone, wakes up one morning and finds out, their family member died in a car accident. Another way that they could be exposed to it is by experiencing repeated or extreme exposure to the aversive details of the traumatic events. So this would be thinking of first responders, CYFD investigators, or police officers, firefighters, people who as part of their job, let's say, or as part of their role are constantly exposed to the details of traumatic events, even though it may not be happening to them. So of note, this doesn't apply to exposure to trauma via electronic media, television, the movies, or pictures, unless this exposure is work-related. So, there's been lots of course, traumatic events that have been happening in our world today. And you might watch the news and see all the footage, and they just repeat it over and over and over again. That in and of itself is not going to cause PTSD. However, if as part of your job, you have to watch this stuff over and over and over again. I can give you an example. I met a woman once who worked for the police as an investigator, I think, and she worked specifically on a unit that focused on child pornography. And her job entailed basically searching the web and searching these child pornography sites. So day in and day out, she's just exposed to this material. That absolutely could cause PTSD. Okay, so focusing on the different categories of symptoms. There's 4 categories of symptoms for PTSD or PTS symptoms. And one thing that I often say to families who their child or even the family overall is experiencing PTS symptoms is I explain that this is a normal response to an abnormal situation. And I say that to try and be validating. I say, given what you went through, which is is atypical, is not something that was, expected to be part of your life, it makes sense that you are having these difficulties, right? This is how your body, this is how your mind has reacted to this in a way to try and keep you safe, right? And so again, I share that to try and validate. Let's look at these symptoms. So we have first the intrusion symptoms or re-experiencing symptoms. And these are, some examples of these symptoms are repeated or involuntary memories of the trauma. So the trauma keeps popping up in this individual's mind. This may look like repetitive play. Perhaps the child keeps, particularly with young kids, over and over again, having violent play, let's say. They've been exposed to violence. Nightmares, having flashbacks or feeling like you're back at the time when the trauma is happening again. And with little kids, this sometimes looks like trauma-specific reenactment in their play. So perhaps a child who experienced, let's say, was inappropriately touched by someone in their play, they're taking dolls and reenacting this event. This may also look like distress when reminded about the trauma. So whenever the trauma is brought up, I'm experiencing emotional distress, and I also may be experiencing physical distress. I have physical reminders physical reactions when I'm reminded of the trauma, such as stomach aches, my heart beats fast, trouble breathing, feeling sweaty, things like that. Our second category is avoidance symptoms. We have two examples of this. So this might be avoidance of the memories, thoughts, or feelings related to the trauma. So this might look like anytime someone asks me about the trauma, I either refuse to talk about it or I completely shut down. This might also be that, I have on here, I avoid thoughts or feelings related to the trauma. So perhaps I'm avoiding things that cause me to feel similarly as I did when the trauma happened. So for example, as a very, very simple example, perhaps, I experienced fear during the trauma. So now I am avoidant of scary movies and Halloween and anything that causes me to feel fear. Again, very simplified example, but just to help show what that is. And then avoidance of reminders of the trauma. So let's say the trauma happened in the dark. I'm now scared of the dark. The trauma happened in a car. I now don't want to be in a car. Right. So really it's more that one is more directly tied to, we can see, okay, this is related to the trauma and this is what this individual is avoiding. Our third category of symptoms, which was new to DSM-5, at least in organization, is the negative mood and cognition symptoms. So these would be, some examples of this are the inability to remember important aspects of the trauma, intense negative beliefs or expectations about the self, others, and the world. We're going to actually come back to that in a few slides. Self-blame, so taking responsibility for the trauma when, perhaps it was not my responsibility. Experiencing a persistent negative emotional state, so persistently feeling angry, feeling shameful, feeling fear. Having a diminished interest in activities I used to enjoy. So I no longer want to play baseball. I no longer want to spend time with friends, do the things that used to be fun to me. Feelings of isolation and distance from others, just not being as close in my relationships. And then a persistent inability to experience positive emotions. And this can sometimes, people refer to this as emotional numbing. The individual may say, I just feel nothing. And our last category is hyperarousal and reactivity. So examples of this are, sorry, I have to rub my nose. Examples of this are irritability and angry outbursts, reckless and self-destructive behavior, which can look like many different things. We tend to see this in teens and young adults particularly. Hypervigilance, so always kind of on the lookout for what's going on around me. And similarly, an exaggerated startle response. Any noise, I have a big reaction to, or I'm jumpy. Having concentration difficulties, which is very common in many different diagnoses, but we see a lot with individuals who have experienced trauma. And then similarly, having trouble sleeping. So some other difficulties that can be trauma related, and I emphasize can because most of these can happen, even in individuals who have not experienced trauma. But in individuals who have, we might see school avoidance, toileting issues, attachment-related behaviors like clinginess or rejection of affection, that general emotion dysregulation. So I just have really strong reactions to things. I seem to overreact. I don't soothe. At times I may underreact, just kind of all over the place in my emotions. Difficult to soothe, as I said. Eating disorder behavior, substance use, sexually acting out, and running away. Again, many of these, not all, but many of these can occur even without trauma, but they also can be trauma related. So, and I just wanted to emphasize that. Let me grab a tissue. I just wanted to emphasize that because sometimes people will be quick to say, oh, this child is having this behavior, they must be traumatized, right? This child is promiscuous, there must be trauma. This child is wetting the bed, there must be trauma. And that's not true. We cannot diagnose, assign trauma to someone based on their behaviors. But these are things we might see in someone who's experienced trauma. Okay, sorry, my slideshow paused. So just a couple more stats, but I really want to highlight not just the impact of trauma in the immediate, but these are more thinking of adults and long-term consequences. So, and I apologize, these are depressing stats. I promise by the end of the presentation we'll take a more positive spin. But people who've experienced trauma are 15 times more likely to attempt suicide, 4 times more likely to have alcohol abuse, 4 times more likely to develop a sexually transmitted infection, 4 times more likely to inject drugs, 3 times more likely to use antidepressant medication, 3 times more likely to be absent from work, 3 times more likely to experience depression, 3 times more likely to have serious job problems, 2.5 times more likely to smoke cigarettes, 2 times more likely to develop chronic obstructive pulmonary disease, and 2 times more likely to have a serious financial problem. So again, this speaks to the global effect of trauma. It's not just about the symptoms we're experiencing, but really how it can have these long-term consequences. So I said we come back to that negative mood cognitions category from PTSD, and this is where I wanted to do that. I wanted to spend some time looking at what are common emotions and cognitions or thoughts that individuals have, particularly kids, after they experience trauma. In cognitions, thinking about, my thoughts about myself, the world, and others. So some common experiences are feelings of guilt. For example, a thought like, it's my fault my dad hits me. Feelings of embarrassment. Everyone can tell what happened to me. Feelings of shame. I'm different from everyone else because of what happened to me. Feelings of helplessness. It doesn't matter what I do. Bad things happen anyway. Having revenge fantasies. I should have taken the gun from him. Altered perceptions about your own strengths. What if I'm not really good at math after all? Concern about safety of others in the world. Thoughts like, I can't trust anyone. Others will hurt me. And predicting failure or being risk averse. So there's no point in trying, I'll just fail anyway. So what I wanted to do next is take some time to look at the experience of trauma as it looks across the developmental spectrum, and starting with the school-age child, so elementary, middle, and then looking at adolescence, because it really looks different, of course, as individuals develop. So looking at the trauma experience from a school-age child, I did not read, this is like a direct quote from NCTSN, who are the experts on childhood trauma, and it was so good I wasn't about to change it, so I will just read it. School-age children start to face additional dangers with more ability to judge the seriousness of a threat and to think about protective actions. They usually do not see themselves as able to counter a serious danger directly, but they imagine actions that they wish they could take, like those of their comic strip heroes. So in traumatic situations, when there's a violence against family members, they can feel like failures for not having done something helpful. They may also feel very ashamed and guilty. They may be without their parents when something traumatic happens, either on their own or with friends at school or in a neighborhood. Sexual abuse occurs at the highest rate among this age group. School-age children get scared of the speeding up of their emotions and physical reactions, adding new fears to the danger from the outside world. And a quote from an 8-year-old child who had experienced trauma, "My heart was beating so fast, I thought it was going to break." So this really highlights, at this age, at the school age, some of the unique factors that come up, and we'll look at them more specifically in the next slide. But one thing we talk about is the hero complex. So sometimes kids will say that they did something to intervene, even though it may not be true. And this isn't pathological in and of itself. It's really their way of making sense of, I didn't have any control, and I don't have any control in my world, and I want to. So they may say, and then I stopped my mommy from hurting my daddy. It may not be true, but it's sort of their way of trying to make sense of all this in a way that feels more comfortable to them. We also see more feelings of helplessness and misassignment of fault. So where the blame is being placed can be not appropriate. So we're going to look at elementary and then middle school age, some of the behaviors you might observe. And what we'll find is that there's a lot that's similar, but there's some subtle changes throughout the years. So in elementary years, we see anxiety, fear, and worry about safety. We see more moodiness, irritability. We see increased inactivity level, more concentration difficulties, aggression and anger, and sometimes withdrawal. We see distrust of others and social difficulties, which could be related. We see difficulties with authority or with redirection or criticism. We tend to see more physical complaints, so a lot of trips to the nurse's office. We see change in school performance. We might see recreating the event, so drawing pictures of the trauma, repeatedly talking about the trauma, or playing it out. We might see emotional numbing, so this child may seem to have no feeling when they talk about the event. They just talk about it with a straight face, no emotion, and then we may see PTSD symptoms. In the middle school age group, we see, again, a lot of similarities, but some subtle differences. We see the fears about safety. We start to see worries about recurrence of the trauma or about the consequences of violence or trauma. And this is, in thinking about as older they start to get to this preteen, teen age, they really can start to think a little better long term, right? So they're not just thinking of what's happening to me now, but also what might this mean? Might it happen again? Similar changes in behavior, again, the physical complaints, the change in academic performance. We sometimes start to see discomfort with feelings in general. So they may have troubling thoughts of revenge. They want to get back at the person who instigated the trauma, but that may be distressing to this child. You may see repeated discussions of trauma and focus on specific details of what happened. So there's just a certain part of what happened that they focus on. They may start to have repetitive thoughts or comments about death and dying, and this may or may not be directly related to the trauma, but this is again more about, they're thinking of the long-term consequences. They're realizing that their worldview of what is safe is different, so they may start to think about their own mortality. You might see over or under reaction to triggers, trauma triggers, which we'll talk about in a little bit, and emotional numbing and PTSD symptoms. Now looking at adolescents or high schoolers and late middle schoolers. So again, taken from NCTSN. With the help of friends, adolescents begin a shift towards more actively judging and addressing dangers on their own. This is a developing skill, and lots of things can go wrong along the way. With independence, adolescents can be in more situations that can turn from danger to trauma. They can be drivers or passengers in horrible car accidents, be victims of rape, dating violence, and criminal assault, be present during school or community violence, and experience the loss of friends under traumatic circumstances. During traumatic situations, adolescents make decisions about whether and how to intervene, and about using violence to counter violence. They can feel guilty, sometimes thinking their actions made matters worse. Adolescents are learning to handle these intense physical and emotional reactions in order to take action in the face of danger. They're also learning more about human motivation and intent and struggle over issues of irresponsibility, benevolence, and human accountability. And looking at what some high schoolers may display in the wake of trauma, again, some similarities, some differences. So the fears and the worries about safety, again, the worry about consequences of the violence or about the violence reoccurring or the trauma reoccurring. In terms of their behavior, we tend to see more impulsivity and risk-taking behaviors. So perhaps this is, and I have on here the next one, more substance abuse, promiscuity, running away, not following rules, just like poor decision-making, concentration difficulties, withdrawal, irritability. We might see distrust and negative perceptions of others. Again, the discomfort with feelings, discussion of the trauma, and repetitive thoughts related to the trauma and also mortality. Again, reactions either over or under to triggers. We tend to see more issues with authority, redirection, or criticism again. And similarly to the other two age groups, emotional numbing and PTSD symptoms. So I want to spend some time actually focusing on school because, our youth spend a significant portion of their time in the school setting. So inevitably, when someone experiences trauma and is struggling to cope with that, it's going to impact their school performance and just their functioning in school overall. And, I like this comic. It's sad, but I think it speaks really to the seriousness of this and why school is important to consider, this child says, "Can someone help me with these? I'm late for math class." And you can see he's carrying these suitcases of sickness, hunger, and homelessness. And it just highlights how, we often don't know what's going on with our kids, particularly in a school setting or really in many settings, yet our expectations stay the same. So this, they still have to get to class, they still have to do their homework despite having all these stressors, all this baggage that is being carried around. So why schools matter? Trauma affects school performance. We see lower scores on standardized achievement tests. We can see decreases in IQ, particularly with chronic complex trauma, decreases in reading achievement and language, and higher rates of retention, grade repetition, as well as dropouts. Trauma can affect not just performance in school, but the actual learning of materials, because executive functioning skills are impacted. This is planning, the ability to plan, the ability to organize things, and the ability to actually execute, to do things is impacted. As we just looked at in the past couple slides, obviously behaviors that can be impacted by trauma, so it's going to impact how someone is behaving in school. We see higher rates of suspension and expulsion. And school matters because for many kids, not all, but for many kids, school is a place of safety and security, and it's a community gathering place. So it can really be a place that's a protective factor if we can make it such for a child. Now, that's not to say that there's some kids whose school is not their safe place, whether the trauma happened in school, whether they're fearful of what will happen while they're at school. So we do see some kids where there's school avoidance and they don't want to go to school. But for a good portion, school is maybe the only place they're getting meals, the only place there's predictability. So we really want to spend time addressing that. So I said I'd come back to the single incident versus chronic trauma, and that's in terms of how it can impair learning. So our single incident trauma can impair concentration and memory because of basically the PTS symptoms. So jumpiness, intrusive thoughts, moodiness, sleep disruption, social withdrawal. Whereas the chronic trauma, particularly in early development, really impacts things even more globally. So we have the impact, the ability to pay attention, the ability to remember things, the ability to think clearly. It can affect the ability to focus, organize, and process information. So if I cannot focus my attention, if I cannot take in the information, organize it in my brain, and then remember it, my ability to learn is dramatically impaired. My problem solving or my planning could be impacted. And then obviously my emotion dysregulation, feelings of anxiety, frustration, is going to impair my school performance. And I apologize, I'm going a little bit quicker because I'm just noticing time and I want to get to the positive spin on everything. But finishing up here, so trauma triggers. There's a lot of things in school that could be triggering to youth who have experienced trauma, and they're often not predictable. But a couple of examples, and then we'll go through a more exhaustive list. Thinking others are violating their personal space. So feeling like anytime someone is looking at them or staring at them, that is an affront in some way. I have someone I work with which this happens. And think about in a school day, how many times people look at someone. If that is intimidating or is a trigger for you, that's going to really disrupt your entire school day. Having reactions when interacting with authority figures, fighting when criticized, or struggling with transitions, which is very common with little kids. Looking at more specific triggers. So we have loud noises, which if you think of a school, there's an incredible amount of noise. We have bells, a loudspeaker, doors and lockers slamming, noises from the street, and all the voices. If you think of the hallway, all the reverberation of all the noise, that can be really overwhelming. And then on the opposite end of the spectrum, some individuals are triggered by low stimulation, by the quiet, by the darkness, by having their eyes closed. Sometimes the physical proximity to others can be a trigger, so it's important to consider the gender, age, role, and rapport between the two before there's physical proximity. For some individuals, isolation is a trauma trigger, so being separate, being sent to timeout or sent out of the classroom, that could be a trauma trigger. Discipline, competition, even healthy competition can feel like a trauma trigger, particularly if it's invoking feelings within the child that are reminiscent of the trauma. Authority, just dealing with authority in general, could be a trauma trigger for the child. Transition, as I said before, there's a lot of transitions in the school day. Special events, so things that disrupt the flow of things. Let's say it's a celebration, it's an assembly, a field trip. The predictability of my day is off. That can be triggering for me. School assignments focusing on sharing personal experiences. So this comes up often in English class, humanities, writing journal entries or essays that have to do with personal experiences. That for someone could be triggering. And then finally, energy-raising activities. So if you think of gym class, for some, that increase in physical arousal can be triggering and distressing to the child. Okay, so I promised we would get to a more positive spin. And I really wanted to spend some time talking about, we just spent almost a whole hour talking about how trauma can negatively impact an individual's functioning in life. But the reality is that not every person who experiences trauma is going to present with these difficulties. And it's important to think about as providers, because otherwise it's very difficult work no matter what. It's sometimes hard to think, man, how do I help these families to grow, to sort of get better? And that's thinking about resiliency and post-traumatic growth. So children and families possess competencies, psychological resources, and resilience, often even in the face of a significant trauma, that can protect them against long-term harm. So there's innate things and some things that have been already fostered within a family or a child that can actually serve as protective factors for how this family is going to cope with trauma. And as I said before, not everyone who experiences trauma develops maladaptive post-traumatic stress reactions. For those of us who work in the behavioral health sector, we tend to primarily only see those who are having these maladaptive responses. Most people don't come to, behavioral health and say, well, I had a trauma, but I'm doing really well, and I just wanted to come anyway. Usually they're coming because they're having all these difficulties or piecing together the whole puzzle of what has gone on in their life. So it's important to remember that and use that as motivation to kind of help this individual regain more adaptive functioning. And something that I always share with when I have a family and I have a caregiver that's going to be involved in treatment, or even I'm, let's say, doing an assessment, an eval, and this is a family who I'm referring or recommending for treatment, I'm trying to motivate this caregiver. I let them know that a critical protective factor for children who experience trauma is having at least one supportive, positive, and protective caregiver. And this is huge. And I tell parents that, the number one predictor of which kids sort of do better, get better, even amongst all those that are in treatment, is having at least one supportive caregiver. And I tell this to caregivers, not just as a motivator, but more just to let them know they're doing something right. Oftentimes caregivers are coming to us and they just don't know what to do. And they feel like, oh my gosh, my child has experienced this or my family's experienced this. And I feel like I failed them or I just don't know how to help. And just letting them know by you being here today, by you being at this doctor's appointment or this therapy appointment or coming to their school, whatever it may be, you are already going along the path of helping them to recover from this and be resilient. And I just find it to be so powerful. And, oftentimes caregivers, no one is telling them, oh, you're doing the right thing. So I really try and highlight that with them. And then just 2 slides left. The last 2 slides are just focused on specific factors that are really protective for post-trauma adjustment or resiliency. And that is, like I was just saying, positive bonds with caregivers, having positive relationships with other nurturing and competent adults. So it's not just about, obviously the caregiver-child dynamic is huge, but it's also about what are their relationships like with other adults? Do they have positive relationships with teachers, with coaches, with other adult family members? That is really going to be protective. Intellectual skills, self-regulation skills. So does this child either innately or has already been taught how to regulate themselves, how to manage their behaviors, manage their feelings, manage their bodies in space? And then positive self-efficacy, which is similar to self-esteem, but really more globally about having thoughts about, I can do this. I have the ability, I have the strength to do X, Y, and Z. And just having those core beliefs and that core confidence in the self really goes a long way for actually not just protective factors in the face of trauma, but in terms of mental health overall. And I wanted to highlight these because it's important for those of us who are working with kids to think about how can we foster these things in the kids we're working with. We may not be able to change their intellectual skills, but self-regulation, self-efficacy, working with caregivers to ensure a stable, secure relationship with their child, things like that. And then some other things are, studies find that actually having faith and hopefulness and just a sense of meaning in life is protective. So it's not that there's one specific religion someone needs to be, but it's just having that sort of belief in, things will get better. That sense of hope is a big protective factor. Having supportive, positive friendships and relationships, being involved in effective and appropriate school settings, other pro-social organizations, so clubs, groups, sports, being in a community that has positive services and support for families and children. So feeling like, this family is not just dealing with it on their own, but there's others out there to help guide them through this. And then finally, being part of a culture that provides positive standards, rituals, relationships, and support. And again, culture is a very general term. So it could be the culture of the family, the culture of the community, the culture of, religion, ethnicity, whatever it may be, but being in that culture that really provides that positive support. And that is all I have. My last slide is just providing you with the references that I've referenced throughout the slides today so that you have those in the event that you want to look any of these up. And I really appreciate you joining my presentation today. Thank you.